the app on their phone? I'd just like you guys to open. That will be a point of reference. Is there anybody who doesn't understand Kiswahili here?
Yes.
Okay. Everybody has the app open? Casualty app, casualty app. Okay, procedural sedation algorithm. It should be the last algorithm on that list. It's the last one. Okay, everybody is there? All right, we can start, guys. We are good? All right, welcome, guys. My name is Kevin. I practice emergency medicine at Aga Khan University Hospital here in Nairobi, okay? So this station is about procedural sedation and analgesia, okay? They are two different things. Most people usually just think sometimes when you give sedation, it counts as analgesia. It's not, okay? So just to start off, what do you understand by procedural sedation and analgesia? Don't use the words. Don't use procedure, don't use sedation, don't use analgesia, okay? Just a rough idea. Anybody?
Sleep, put to rest.
Put to sleep, put to rest.
Painkiller.
Okay, painkiller. For what? What's the end goal? What do you want to do for the patient?
Of an agitated or long procedure, agitated patient.
Okay, he wants to reduce agitation if you're doing a procedure. Okay. Ultimately, end goal?
Pain-free.
Pain-free, that's one. Another one?
Maintaining cardiorespiratory function.
Maintaining, that's an adjunct. You actually want to do that throughout the procedure, okay? Goals of procedural sedation and analgesia. So in the algorithm, that first sentence, what do you want to do? Primarily, to make the patient comfortable, for you to be able to do whatever you want to do. And I'll add safely, okay? It has to be safe, both for you and for the patient, all right? Is that clear? So in what scenarios do you do procedural sedation and analgesia? It's still in that algorithm, that first paragraph. Yeah. Where do you apply it? Okay. So musculoskeletal injuries, dislocations, especially shoulder dislocations, very common. Imaging. There are people who can't stand being in that MRI machine. Maybe you're doing scoping, you want to get a foreign body, okay? Or you're looking at somebody's GI tract, okay? Endoscopy, colonoscopy, okay? What else? Cardioverting. Where do you apply cardioversion? Sorry? Unstable arrhythmia. Okay, where do you apply cardioversion? He's right. Just basics. Tachycardia. Sindio? Is it all tachycardia that you cardiovert? What kind of tachycardia? Unstable tachycardia. Is it narrow complex, wide complex? Does it matter? Does it matter? If the patient has BPs of 60-40, it's narrow complex, it's wide complex, does it matter? It doesn't matter, okay? And if you go through the tachycardia algorithm, you'll realize for both narrow complex and wide complex, if the patient has signs of instability, there are like 5 or 6 signs of instability, you cardiovert, okay? All right, where else?
PIDS.
For?
PIDS.
Where? For PIDS? What in PIDS? Okay. Pediatrics are usually quite anxious. 5-year-old has a small laceration here. Do you want to sedate them? Do you want to sedate them? For you to put 2 stitches here. Do you want to sedate them? What do you want to do?
Pain.
Do you want to control their pain? Do you want to make them less anxious?
Yes.
Okay? So goals of procedural sedation and analgesia. Okay? Sedation is a goal. Okay? Pain control is a goal. Anxiolysis is a goal. Sometimes you can go as far as you say amnesia is a goal, just because of the kind of medications that we are giving. All right? So what I'll tell you is that, is there anybody here who has a hospital, who owns a hospital where they work? Who owns the hospital where they work? Or we are all employed? That's true for all of us. Okay? If your facility does not have a policy that allows you as an emergency practitioner to do procedural sedation and analgesia, don't. Okay? If your facility does not allow you, please don't. Let the people who are allowed, majority of the facilities, it's usually anesthesia that is allowed to do this. So don't just go and say, I've been trained, I can be able to do this, I think I'm good enough. Don't do it. You lose your job. All right? If your facility has that policy, well and good. Okay? Where I work, we are trained, and you have to recertify that training yearly for you to be able to do this. Okay? So if you don't have that policy in your hospital, please don't put yourself in hot soup with the management of the hospital. We don't want to fight those kind of battles. Our jobs are hard enough anyway. Okay? So what's the first thing before you even, somebody has walked in with a shoulder dislocation. What's the first thing before you start assembling your equipment? What's the first thing? Consent. Okay? And you're saying the right thing, informed consent. Okay? Not everybody who has a shoulder dislocation wants it reduced in the emergency department. Okay? There are people who would prefer to be admitted to undergo general anesthesia or a full sedation in the operating room for a shoulder dislocation. Okay? So don't just assume it's just a shoulder dislocation. Hey, let me put you here, leta mkono tukuwekea line. Don't assume. It has to be informed consent. Okay? What is informed consent? Guys. So you're telling the patient what they have, okay? What they have, okay? So you try and find out if they understand what's going on with them. So it's a shoulder dislocation. You have to tell them, this is what has happened. One of the joints in the shoulder, because there are like 4 of them in the shoulder, has come out. We need to put it back. Sometimes you tell somebody, I want to reduce your shoulder. Do they understand? What are you reducing it to? They don't know what reduction is, what reduction means in medical terms. Okay? So you have to tell them what you have, what you want to do to them. Okay? How you will do it. What are the benefits of what you will do, and what are the risks and consequences of what you will do, and what are the alternatives. You have to give the patient all this information before embarking on whatever you want to do. Is that clear, guys?
Yes.
Okay? And informed consent before any procedure is signed. Okay? If the patient is there, it has to be signed. If they are not able to sign, it has to be next of kin to sign. Okay? If there is no next of kin, it has to be 2 professionals. Either if you are 2 doctors, one of you can sign on behalf of the patient. Okay? It has to be 2 practicing practitioners signing on behalf of the patient. If the patient is not able to sign, there is nobody next of kin to sign on their behalf. Okay? It has to be documented. All right? There are some times where people usually say, I obtained verbal consent. That verbal consent has to be documented. Is that clear? All right. So after that, you've obtained consent. What's the first thing? Principles of emergency medicine. Okay? Safety. It's you first, then the patient. If somebody has been knocked down on Tomboya Street at 11 a.m. in the middle of the day, and you are there, you are walking, do you attend to them? Does the principle of, does the Good Samaritan law apply in Kenya? Does it apply in Kenya? Does it apply? It does not. Okay? The moment you engage that patient, you take full responsibility. That's why in most facilities, as a Good Samaritan, umejitolea, you're taking somebody to a hospital. Even in Kenyatta, you want to hand them over to the ED, they will make you stay there until that patient has been signed, has an account number, or their next of kin has arrived. Okay? So if you take that responsibility, you have to go the full way. Okay? So safety. Your safety first, then safety of the patient. Okay? So we, for purposes of this discussion, we assume we're in a facility, we're in a hospital. All right? Patient has come, has a dislocation, has a fracture, is bleeding. So what do you want to do? This is just to demonstrate personal protective equipment. Always glove, if you have a gown, if you need a face shield, mask, whatever, that's the first thing you do. Okay? Protect yourself before you can start attending to the patient. Okay? So, for me, every time I'm doing procedural sedation and analgesia, at the back of the mind, I always think like I am going to intubate this patient. Just because of the kind of medications that we give. If you're not comfortable managing somebody's airway, please don't do this. Okay? It doesn't mean that you're not able to intubate. Managing or keeping somebody's airway open and patent. If you can't do that, kindly, please don't attempt this. Most of these medications, you realize that when you administer it, somebody just stops breathing, or their respiratory rate drops, their oxygen levels drop. It has happened to me once or twice, okay? Giving somebody a very small dose of an anxiolytic, benzodiazepine, midazolam, 2 milligrams, okay? And they went completely out. And they had to be intubated. Okay? So at the back of your mind, every time you are administering procedural sedation, anytime you're administering those kinds of medication, at the very least, nasal prong. It doesn't matter whether you have the perfect lungs. Anytime I'm doing this, all my patients will be on oxygen. It's just a safety precaution. Is that clear? Yes. Okay? I think it's also that first part of, when you look at that algorithm, in that first or second paragraph, airway. It's all about, emergency medicine is more about preparation than the actual thing that you are doing. You prepare, you anticipate complications, you anticipate whatever risks happening. Okay? That's it. You realize, how long does it take you to push fentanyl? 25 micrograms. How long does it take? Seconds. Okay? How long does it take for you to push a medication? Line is in place, it's patent. How long does it take? Literally, like this. Then, what if the patient goes down? What if they stop breathing? So if you can't manage somebody's airway, if you can't keep it open, kindly don't do this. For your own safety, especially legally, okay, and for the patient's safety. Is that clear? So you'll notice that I've arranged my equipment here in order of how you're most likely going to use them, how you're going to scale up, okay? At the very least, nasal prongs, okay? Oxygen delivery devices. So as the oxygen requirements keep increasing, You keep escalating. This is just to mimic a simple face mask. Okay? Non-rebreather mask. Oxygen requirements are now more than 10 liters. Okay? Beyond this, now you have to bag the patient. Okay? Oxygen adjuncts, oropharyngeal airways. But before this, before you're putting an oropharyngeal airway, can you open that airway? Can you open the airway? Head tilt, chin lift. Everybody should be able to do that. Head tilt, chin lift, or a jaw thrust. Okay? I think you've gone through a workshop that has this airway management. Okay? Procedural sedation and analgesia is more to do with airway than actually what the procedure is. Okay? Is that clear? So, as you proceed, if you're bagging the patient, bag valve mask, then sometimes you get to areas where you need to put definitive airways. You need to intubate the patient. Intubation is not successful. You need something to help you. Supraglottic devices. Has everybody ever seen this? Is there anybody who's never seen this or doesn't know what this is? Anybody? What is it called? Igel is a brand name. Laryngeal mask. It comes in different sizes. It comes in different forms. There's one that is already commercially prepared. There's one you have to inflate. There's one that comes with cuffs, like this one. Okay? Different brands have their own types. Okay? ETT tubes. Intubation. Everybody has seen an ETT tube. Okay? So, when I said I'm intubating the patient, ideally, you shouldn't be worried about intubation. For me, intubation is never an emergency. Even those rapid sequence intubation, that act of laryngoscopy, direct laryngoscopy, putting in the laryngoscope so that you can be able to visualize the code, that's never an emergency for me. It should never be an emergency. If you can open somebody's airway and deliver oxygen, usually if you're able to bag the patient, well and good. Okay? Are we airway experts? Is our training more to do with airway? Who are the specialists that deal with the airway? Anesthesia. Okay? So airway does not have shame. Sometimes you find a patient who has a very bad airway, bad Malampati score, short, thick neck. Okay, they have dentures. It has happened to me. And then you attempt intubation and it goes in. Fast pass. Okay? Sometimes you have a patient, perfect airway, no Malampati, hakuna kabisa. You attempt first time, you fail. You attempt second time, you fail. You get one of your colleagues, they attempt, they fail. You go as far as getting the anesthesia, they come, they fail. Okay? In all these trials, if you're still able to bag the patient, well and good. Okay? Intubation for me is never an emergency. It should never be. So long as you're able to keep the airway open, parted, deliver oxygen, you're fine. Is that clear, guys? All right. So we go down that algorithm. What's the next thing? The drugs themselves. How many drugs are listed there? Three. What, and what? There is ketamine, fentanyl, midazolam. What else? What else? They're just three. Okay? So it really depends on what you want to achieve when you're giving procedural sedation and analgesia. All those goals, is it sedation, is it analgesia, anxiolysis, amnesia? Okay, there are people who just want pain control. Rugby player has had recurrent shoulder dislocation, is not really bothered by it, just wants the shoulder back. So just tell you, just give me some paracetamol and do what you need to do. They've given you consent. They want to be aware, fully awake while doing that. The people who don't want to, who don't just want pain medication, they want a bit of sedation. Sometimes they don't want to remember, they are quite anxious. Okay? Whoever you're doing the procedure to, the kind of patients that you're seeing. 7-year-old with a fracture, as opposed to an 89-year-old or a 40-year-old, or the rugby player, 25-year-old muscular guy, healthy, fit, and an 89-year-old diabetic hypertensive, has end-stage renal disease on thrice-weekly dialysis. Do you want to do procedural sedation on them? Do you want to? Why not? Why not? Okay. Are those comorbidities, do they limit you from doing procedural sedation? What do you guys think?
I think they don't limit you, however, it will be, you anticipate difficulties.
Yeah. So at the back of your mind, you need to know who your patient is, what's their baseline functional status. Okay, that goes with the medications that you're giving. Ketamine is my choice drug when I'm doing procedural sedation, simply because I like to avoid polypharmacy. If I can give one drug that can achieve all my goals, I will go for it. Okay, so I prefer ketamine. I am comfortable using ketamine. Okay, because it does two things for me, both sedation and analgesia. Okay, I don't cram the doses. I don't even know the doses of these medications. I refer every time. So even if I've reduced 2 shoulders in the morning, splinted a fracture, in the afternoon, if there's another patient, you'll always find me opening the app. Okay? In emergency medicine, we don't have shame. That's why even in resuscitation, we always remove the algorithm. You don't want to be getting things from the back of your mind. During an active resuscitation, you're trying to think, okay, we've given adrenaline. Do we shock next? Do we give amiodarone? What's the dose? Do we start with 300 or 150? Do you want to be having those kinds of thoughts during a resuscitation? No, it's not safe for the patient. Every time, refer. Okay? With time, you do this long enough, you find that you actually know those things. But you have to refer. If your facility has a checklist, we have a sample checklist in the algorithm, you can go through it. It's always the best way to make sure you are not missing anything. Is that clear? So let's start with the first drug, ketamine. There are relative and absolute contraindications, okay? If your patient has any psychiatric history, I know the algorithm says, is it schizophrenia, those schizoaffective disorders? But if your patient has any psychiatric history, don't. Please don't. It doesn't matter whether it's depression, psychosis, any schizoaffective disorder, please don't. Okay? One of the adverse effects is that dissociative state. It happens to 60-70% of the people who receive ketamine. The other absolute, I think is it neonates? Less than 3 months. Okay? Those ones you have no reason really to be using ketamine less than 3 months old. Okay? Can you give it safely for people with end-stage renal disease or any renal disease? Okay? If somebody is on thrice-weekly dialysis, does it matter really? They're going to be dialyzed anyway. Sindio? Can you use it for hemodynamically unstable patient? Hypotensive, not perfusing? It's usually the go-to drug. for such scenarios. Okay. What about if somebody is they're in pain? Because of the pain, blood pressure systolics of 180. Do you go for ketamine? Hmm? Do you go for it or not? Do you go for it or not? Why not? Why not? Is there any standard dose for ketamine? Is there any standard dose? Like you have to receive 2 milligram per kg for shoulder reduction. You have to receive 2 milligram per kg for rapid sequence intubation. Is there any standard dose? There is no standard dose. It's what you want to achieve. Okay. Remember, right now, ketamine can, even psychiatrists are using this for major depression as a continuous infusion that lasts 12 hours. I don't know why, but it actually helps. Is that clear? Okay. So those contraindications, indications for these drugs, you have to know them. Before administering any medication, you have to know what this drug might do to your patient and what are the adverse effects. That's why that table is there. For me, every time, yes, I know maybe patient is hypotensive, I can give it, but I have to look at that table. Every time. We are all about safety. Is that clear? Okay. What are the other drugs that we use?
So is there, excuse me.
Yeah.
So in the table it says 1 milligrams per kg.
Okay.
Is that the lowest dose or you can titrate it?
You can titrate it. So below 1 milligram, you actually have now to do dilution and all those things, but you can titrate it. Okay. So commonly in most of our EDs, we have benzodiazepines. Midazolam is the commonest. Okay. Also, it can give you sedation if you give the right amount of dose. Primarily, most people like it for anxiolysis. Patient is very anxious. They've looked at the X-ray and they've seen the bone is fractured midshaft. Okay. Very small dose, 1 milligram, 2 milligrams. They are calm and you're able to proceed with whatever you want to do. Is that clear? Again, you have to know your patient. Okay. If I can give an example, for example, a practicing Muslim, somebody who does not take alcohol. Okay. You have to be aware. Most of these drugs are metabolized through the hepatic system. Okay, so maybe your patient who you are seeing was out all night. They were drinking a lot of alcohol all night. They usually drink. You give 5 milligrams of ketamine and fentanyl, and you're still having a normal conversation. You're still having a normal conversation. Okay, as opposed to somebody who has never touched alcohol, even mouthwash. They've never. You give 1 milligram or 2 milligrams of midazolam and they are out. Okay? So those are the things you need to history taking. Is that clear? So midazolam, anxiolysis, with the right amount, you can actually sedate. Fentanyl, primarily analgesia. Okay? Rapid onset analgesia. If you're using fentanyl, you have to be ready. It's literally like that. Okay? With the right doses, again, you can sedate somebody. It's an opioid. You can sedate somebody with this. Is that clear? So you'll find that most people, they're either using ketamine or they use a combination of a benzodiazepine and an opioid, whatever you have in your facility. Is that okay? So the risks, indications, and contraindications of all these medications are in that table. Okay? Here in Kenya, by law, by law, every facility or every hospital that purchases opioids or benzodiazepines have to purchase their antidotes. Okay? So you might not have seen it, but it's there. It's there. If you ask and you're insistent and you're in an emergency, you'll always find naloxone. It's an emergency drug. Okay? So if your facility has those crash carts, they should have these things. Accidents happen. Okay? Flumazenil for reversal of benzodiazepine. Okay? By law, if you have any opioid, including tramadol, in your facility, you have naloxone in your hospital. Nobody should tell you that it's not there. It's there. You can't be sold these drugs without their antidotes. That's the Kenyan law. Is that okay? Is that clear? All right? Always have a bit of fluid for your patients. Okay? Sometimes usually say just to keep the vein open. Okay? Are there any questions up to this point, guys?
So the question would be now, are there guidelines for the reduction of fractures? Because most of the time, it's done with plaster, but that we can reduce apart from using, because also most of us will not be allowed to give these IV anxiolytics.
Okay.
Or even nerve blocks. Most of us are not allowed to do.
Yeah.
So are there guidelines that guide on the best way to reduce the pain?
So the best way is just to get that shoulder back. For most of the time, when the shoulder is back into the anatomical position.
Most of like fractures now.
Yeah.
Let's talk about fractures.
Yeah.
Shoulders. So fractures, reduction of fractures. Humerus, tip feed, manipulation. Yes.
Yeah, manipulation.
That is done in the casualty department.
Yeah.
Are there guidelines on how to manage the pain that does not involve procedural sedation?
Yeah. So what's usually the choice drug for musculoskeletal injuries? NSAIDs. Okay? NSAIDs are usually. So for me, anytime I'm giving analgesia, there is usually an analgesia ladder. I will always start with paracetamol. Always. Unless you have a contraindication. Okay? I will always start with paracetamol. Step up. Give, review. Give, review. Okay? Give paracetamol, pain is not going down, add an NSAID. You can add an opioid like tramadol or whichever if your patient can tolerate it, if they don't have a true allergy to these medications. Okay? He's brought a very nice point about nerve blocks, regional blocks. Okay? With time, this will be scrapped off. Actually, more of the world is moving towards regional blocks for procedures. Okay? It is safer than actually having to monitor somebody's airway. Okay? But you have to be trained to do regional blocks. It works like magic. Okay? If you're reducing a shoulder, you're reducing somebody has mid-shaft femur, mid-shaft tibia, and you do a femoral block up here, and you can do anything on that leg. Okay? Patient is awake, they are just seated on the bed. Guys are struggling down there, they are pulling those bones, and the patient is just comfortable. Okay? That's where the world is moving to. But for that, you actually need training. For you to do regional blocks, you have to have POCUS training because it's under ultrasound. You don't do anything blindly anymore these days. Way down the line, we'll get to a point where even putting peripheral lines, people will say now the gold standard is having ultrasound-guided cannulations. It doesn't make sense in our setting, but there are places you go. Like if you talk to Dr. Bahra, he'll tell you in the UK, you don't do anything that you're not seeing where you're going. That's where the world is moving to. For us, we are still in the infant years. Actually, we are in the... we are still down here. We are still down here. We are still doing procedural sedation and analgesia. If you go some parts of the world and you mention this, you just be laughed off. Okay? So, as with everything in emergency medicine, preparation is usually most important than the actual thing that you are doing. Preparation, safety. Okay? So if you're able to make sure you have all this, it doesn't have to be all of them, or at least make sure you can access them quickly. So, at the very least, if you are going to put somebody under procedure, please, nasoprong. If you don't have nasoprong, if you're not comfortable opening somebody's airway, you have no business. You have no business putting somebody under. Okay? Anesthesia usually don't believe. They actually hate us for giving some of this medication. If you tell an anesthetist that you're giving ketamine in the ED, oof. Okay? There are some places where people use propofol. Do you guys know propofol? That white, milky substance. Okay? In my experience, it is very hard. It's very hard to be able to monitor patients on propofol. That's why, for the purposes of at least EMKF and this training, even in the algorithm, I don't know, is there propofol mentioned anywhere there? Okay? The pharmacokinetics, pharmacodynamics of that medication, they limit us to administer it and monitor the patient safely in the emergency department. So I don't advocate for it. Okay? For most people who do procedural sedation for imaging, MRIs, it's usually the go-to drug. But those ones are usually on continuous monitoring plus CO2 monitoring. Is there anybody who has CO2 monitoring in the ID?
No, it's in ICU. It's in ICU.
Even Aga Khan, we have to ask for it. We have to ask for a capnograph. Sometimes even in ICU, it's okay? So if you don't have a capnograph, propofol, achana nayo. Okay, leave it alone. Questions, guys?
Quick one.
Yeah.
About the defib.
Okay.
That's, no, cardioversion.
Okay. Mm.
In such a scenario, you need to take both consents, or you're only taking one?
For
Unstable turkey.
So consent for
both
medication and the procedure.
Yes.
Yes.
You have to?
You have to.
Okay.
You have to. Most consent forms has a part for anesthesia, quote unquote, and for the procedure. It has to be both. There are people who will say, okay, but don't cardiovert anybody without analgesia, even if they say, don't cardiovert anybody without, at the very least, analgesia. At the very least, analgesia. Please don't. It's electricity through the heart. Okay? So you cardiovert somebody and then they go out. Please don't. Even if they say they cannot. Even if they say that I'm okay, I can be able to withstand the pain, trust me, nobody can withstand 200 joules of electricity like this. Okay? I hope everything is clear. For me, procedural sedation and analgesia, preparation, anticipation. The part of administering the medication is less than a second. Okay? As with most things in emergency medicine, preparation, anticipation. That's it. Okay? ABCs, airway, breathing, circulation, in that order. Is that clear? Yes. Okay, I think we are done, unless there are any other questions. Last one before we go. Yeah. Yeah, that's what the first thing I said. If your unless you own the hospital, if your facility does not have a policy for you in the emergency department, to administer procedural sedation and analgesia, do not. You'll just be fired. Okay? All right, guys. Thank you for being a good class. You can proceed to the next station.